Good morning, everyone. We'll get started in just a moment. We're letting people join. Hey, welcome everyone to the Kentucky Harm Reduction and Recovery Community of Practice webinar series presented by Voices of Hope and the University of Kentucky College of Nursing. My name is Brooke West. I am a person in recovery and the training coordinator at Voices of Hope in Lexington, Kentucky. The goal of a community of practice is to bring together a group to engage in training, share best practices, and network around a common interest. Today, the topic of our community of practice is developing medication for stimulant use disorder, presented by Dr. William Stoops. Dr. Stoops, the Dr. William R. Willard Professor in Behavioral Science, is a faculty member in the departments of Behavioral Science, Psychiatry, and Psychology at the University of Kentucky. He earned his bachelor's degree in psychology from Davidson College in Davidson, North Carolina, and his master's degree and PhD in experimental psychology from the University of Kentucky. His research, continuously funded by the NIH since 2008, evaluates the behavioral and pharmacological factors that contribute to drug use disorders, focusing primarily on stimulant drugs. He is currently leading multiple human laboratory studies determining the role of various neurotransmitter systems, such as serotonin, glutamate, orexin, in the behavioral pharmacology of a range of drugs from stimulants to opioids to alcohol. Dr. Stoops received a presidential citation from the American Psychological Association in 2021 for his contributions to the field and was named the Researcher of the Year by the Kentucky Psychological Association in 2024. Dr. Stoops is Associate Vice President for Research Integrity and is Associate Director for Clinical Research of the University of Kentucky Substance Use Priority Research Area. We are so grateful to have Dr. Stoops with us for the webinar today. And later in the webinar, we have Dr. Hartley Feld and Tara Stanfield joining us from HealthFirst of the Bluegrass with the resource spotlight, so be sure to stick around for that. And just a couple of housekeeping notes before we begin. If you are a peer support specialist interested in continuing education credit for this webinar, you need to complete the survey that we will place in the chat toward the end of this session. So keep an eye out for that. In the last 15 minutes or so, we'll start putting that link in the chat. And as many of you have found, we have the chat feature on today, so you can participate during the webinar. Please participate, ask your questions. We want this to go both ways here and have you all contribute to the webinar as well. So thank you again, Dr. Stoops, for joining us. I will turn it over to you.
Great. Good morning, everyone. I'm a real pleasure to be with you. I'm going to share my slides and enter presentation mode. So as Brooke mentioned, I really am hoping that this will be interactive. I have a couple points where I'm going to call out and absolutely need input from you. I'll note that I really only plan for about 15 or 20 minutes of content. So I'm going to rely on you all to ask questions, make comments for the remaining 40 minutes of the presentation. And I'll note, anything's on the table. I'm happy to answer whatever I can. Or, if you have comments or thoughts, please don't be shy. I'm gonna hopefully will be able to ask Brooke and Amanda to keep an eye on the chat in case there's anything I miss. And of course, don't wait for the places where I have call outs for you all to put questions in. If you have questions as we're going through, just put them in the chat and I'll do my best to get to them as we move forward. So as Brooke mentioned, I'm going to be giving an overview of how sort of the framework for developing medications for stimulant use disorder. After today, if you want to reach out to me, there's my email address. I am actually still on Twitter, and I'm also on Blue Sky at the handle @WilliamStoops if you want to reach me on either of those platforms. So I thought I'd start by talking about how clinicians diagnose stimulant use disorder. And there's 11 criteria. These are abbreviated versions of those criteria. They're sort of much longer in the Diagnostic and Statistical Manual 5 that's published by the American Psychological Association. And I'm not going to read all of these to you, but they really center around, you know, taking more stimulants than intended or using longer than, trying to cut down but not being able to, spending lots of time trying to get stimulants. Craving was added to the DSM-5 from the DSM-4. It was not there, but craving is a diagnostic criterion now. Using in harmful situations, giving up a sort of more pro-social activities to use stimulants. And you know, the diagnostic criteria, I'm sure as many of you know, the more the more an individual endorses within the past year, the more severe their use disorder is considered. So overall, stimulant use disorder is largely defined by drug taking behavior. And so to receive FDA approval for a pharmacotherapy, the expectation had really been that any pharmacotherapy completely disrupts this behavior, so promotes total abstinence from stimulant use to a greater degree than placebo. Now, I'll note that the FDA has indicated a willingness to move beyond abstinence, requiring abstinence as sort of the sole indicator of a pharmacotherapy's efficacy. But we have yet to bring a pharmacotherapy forward based on this sort of broader definition. So in terms of epidemiology, approximately 5 million Americans used cocaine in the last year, and 1.3 million individuals met criteria for cocaine use disorder. Approximately just under 3 million Americans used methamphetamine, but you can see a greater proportion of those individuals met criteria for methamphetamine use disorder in the past year. I'll note that these levels of stimulant use are actually likely underestimated because the survey from which those data come that I'm citing for you only surveys people who are stably housed. And we know that people who are unhoused or people who are in jails and prisons are more likely to use drugs and therefore are not included in those survey data at the top two bullets. We also know that stimulant-involved overdose deaths are increasing. Stimulant overdose mortality disproportionately affects historically marginalized groups. Okay, so maybe I'll pause and see if there are any questions. Is everybody all right so far?
So far, the only question we have is whether they can have the slides after.
Sure, absolutely. I'll share the slides. Happy to do that. All right, so also to sort of level set a little bit, I thought I'd cover how we develop medications for substance use disorders or just medications in general. This was pulled from an NIH site about developing HIV medications, but the phases are very, very similar for medications for stimulant use disorder. So the idea is that once the drug is approved for testing in humans, so there's been preclinical work in animals done. We think that the drug is safe to test in humans. We first do a phase 1 study, and this is a small phase trial, 20 to 80 participants maximum. And generally, this is done in healthy individuals, so not necessarily people with the disorder that you're interested in studying. So this would not necessarily be done in people with stimulant use disorder, but it would be done in sort of healthy adults. Just to ensure that the doses that you think you need to test in humans are safe and tolerable in general. So I'll harken back to when the COVID vaccines were being developed. You might remember some of those first in human trials. I think there was a person in Seattle who was interviewed as the very first person who got one of the mRNA vaccines for COVID-19. That's what a phase 1 study is, just to determine whether it's safe and tolerable, not whether it has any efficacy against the disorder that you're trying to treat. Phase 2 is a larger phase trial. More participants. This says 100 to 300, doesn't have to be that many, but the difference between phase 1 and phase 2 is you're starting, in addition to understanding safety and tolerability, you're starting to try to understand initial efficacy. So this would be done in the population that you're trying to treat. So if it is a drug for cocaine use disorder, those participants in that phase 2 trial would have cocaine use disorder, and we'd be looking at whether the medication promotes the specific endpoint we're interested in. So I'll go back to that FDA requirement for complete abstinence. Does that medication promote abstinence? Oh, I don't know why I did that thumbs up. Sorry. Um, uh, uh, does it promote abstinence? Now, that would not be sort of the end-all be-all trial. If we get an initial signal of efficacy and it continues to be safe and tolerable in our population of interest, we move it to a phase 3 trial. This is many more participants. This is sort of the, when you think of a clinical trial, this is sort of the prototypic trial, um, placebo-controlled, randomized, multi-site trial across the country with many, many individuals with the disorder that you're trying to treat. After you conduct your phase 3 trial or trials, sometimes there's multiple trials, you submit a drug application to the FDA for approval. The FDA then reviews your application for both safety and effectiveness, and you have to provide all sorts of data to the FDA about pharmacology, toxicology, how you analyze the effectiveness data, and presuming that you meet all your endpoints and the FDA agrees with your application, the drug would be approved. And that, might be the end, right? The drug is out there, it's available for physicians to prescribe, for clinicians to prescribe. But there are phase 4 trials after FDA review and approval. Those are called post-marketing trials, and this can be, in many, many participants. Often these studies are done for additional indications. So a good example of that is bupropion. Some of you may be familiar with that. It's called Wellbutrin. It was initially approved for depression, but clinicians noticed that it was also helping people stop smoking. So phase 4 work was done to get bupropion indicated as a treatment for smoking cessation. And I think I saw something pop up in the chat. Is there a question?
Yes, someone asked, is this always double blind?
Very often it is double blind, particularly the phase 3. The idea is, right, you want it to be the most rigorous trial possible. Now, as the field has progressed, we are starting to think through sort of the design of our trials. So one type of trial that is hard to do as a double-blind trial are studies with psychedelics or hallucinogens, right? It's very hard to blind whether somebody's received a hallucinogen or not. So those trials with hallucinogens may not be able to be double-blind because the participant will often know if they've gotten a hallucinogen or not. But in general, yes, the idea is that they would be double-blind. Great question.
How do you recruit participants for studies? Are they volunteers?
Yeah, so for all of these studies, yes, they need, from phase 1 through phase 3, this all needs to be voluntary participation. All individuals are recruited from the community, screened carefully. They all need to provide informed consent to participate in the study. Often they are compensated for their time, but yes, it is all volunteer participation.
And I'm sorry, I have one other clarifying question that came
Sure.
through. Could you explain what a double blind is and also what you mean by efficacy?
Sure. Let's start with what I mean by double blind. So double blind means that neither the person providing the treatment or, so the study staff, study physicians know what is being administered to the participants, right? They know in general, right? We're doing a trial of drug X, but the actual participant, they don't know what that participant is getting placebo or an active drug. Uh, the double blind part is that the participant is also blinded to the treatment. They don't know whether they're receiving placebo or the active treatment, or if there's multiple active treatments, which active treatment they're getting. So neither side knows, to prevent bias in terms of reporting or expectancy effects, right? If somebody knows that they're getting a drug, they might be expected, they might have some expectancy effects that result in them performing better than if they were blind to the actual study condition. When we talk about efficacy or effectiveness, now those are two different terms, but I apologize in advance because I'm using them a little bit interchangeably. But the idea is that the medication promotes the endpoint that you're interested in, right? So for a pharmacotherapy, again, to go back to the sort of old FDA expectation, was that your medication to be considered efficacious is promoting abstinence, complete abstinence from cocaine or methamphetamine, the drug that you're trying to treat, to a greater degree than placebo. All right. We ready to move on? Everybody, anybody, any other questions? These are great questions. I'm glad that we're already getting really important questions to sort of clarify how this works.
I did get one more, which is if you want to be in a study about this kind of medication, how do you volunteer?
Oh, wow. That's a really terrific question. So, my recommendation is always to look at clinicaltrials.gov. On clinicaltrials.gov, any clinical trial being conducted in the United States, particularly if it's with NIH funding, has to be registered there. So if you are interested in volunteering to participate in a cocaine treatment trial, for example, you would go to clinicaltrials.gov and there's a, very easy to find search bar. It's like right on that front page, and you can type in conditions. Right? There's a section that says conditions. You can type in cocaine use disorder or methamphetamine use disorder, and that will tell you all active studies that are for that specific condition. And you can see if there's a site near you. So I know some people who travel to participate in studies because they really, really are looking for help or they're really wanting to volunteer. So even if there isn't one local, you can find all the sites where work that is being done on this particular condition are active.
That's all the questions, and someone put clinicaltrials.gov in the chat.
Wonderful, thank you. I'll also note we do have at UK, we don't have a whole lot of active medication development trials right now, and you'll see why in a minute. But there's a trials at UK site as well that you can just type in clinical trials on the UK search bar, and that will bring up trials at UK to see if there's any trials at the University of Kentucky that you might want to participate in. And that's all trials. It's not just for substance use disorders. It's for cancer. It's for Alzheimer's. It's for Parkinson's. It's for anything we've got going on at UK is registered there. All right. So let's talk a little bit about stimulant use disorder medications. I've already said this, but we have no FDA-approved medication for treating stimulant use disorder, either cocaine or methamphetamine. That's not for lack of trying. So over 60 medications have been tested across 100 phase 2 and phase 3 trials for cocaine use disorder without one being brought forward for FDA approval. I will note we have had some successes. Agonist treatment, so specifically amphetamine, so think about that as comparable to the use of methadone for opioid use disorder, is effective. It's very effective at reducing cocaine use disorder, but deamphetamine has not advanced as a treatment for cocaine use disorder, and we'll talk a little bit more about why that might be. And I certainly welcome your thoughts about that in a slide or two. For methamphetamine, my best guess is about 25 medications have been tested in about 40 trials. So much less work has been done on a methamphetamine use disorder treatment. There was a trial published several years ago suggesting that a combination of bupropion and naltrexone may be effective. But I will note that when I look at the data for that trial, it only increased, it's statistically significant, but it only increased methamphetamine abstinence relative to placebo by about 11%. So it was not a huge, huge effect. Certainly not anything like what we saw with amphetamine treatment. Sorry, I'm advancing by accident. Any questions about that or thoughts?
Yes, there is a question that says, are you just trying clients on already approved medications to see if they help with stimulant use disorder? I see a lot of stimulant use on Vivitrol and Suboxone, so that's why I asked.
Yeah, really great question. So one of the things that we're hampered by in terms of developing a stimulant use disorder medication is we really are having to repurpose existing drugs. And I'll talk a little bit more about this in a little bit, but getting a drug just to be able to test in humans is a major undertaking, right? And so it's hard to take a novel molecule that has been tested in a rat or a monkey and move it out into clinical trials. So what the field has largely done is tried to evaluate medications that are currently approved in human beings or about to be approved in human beings and test those in cocaine use disorder and methamphetamine use disorder. So yes, we have tried buprenorphine for cocaine use disorder. We've tried naltrexone for cocaine use disorder. and they have met with varying degrees of effectiveness or efficacy. But that is sort of one part of the field that's problematic, is it's hard to bring a brand new medication, a novel molecule forward as a treatment for stimulant use disorder. So this sort of bridges really nicely. Oh,
Bill,
sorry.
Bill, I'm sorry. There's just a couple more comments. Has
Sure.
there been a trial using Wellbutrin and Strattera?
Combined, I don't think so. Now, Wellbutrin has been tried on its own as a treatment for both cocaine use disorder and methamphetamine use disorder. It appears to be more effective for methamphetamine use disorder than cocaine use disorder, but the results are a little equivocal. Strattera has been tried for cocaine use disorder. Actually, that trial was done here at UK, and did not work, to my recollection.
And the last is a more of a comment. If you wanted to react, it says there's a current patient in this person's outpatient treatment facility. They're using naltrexone and bupropion. That's been successful for him with methamphetamine abuse disorder. He's been sober 2 years now, very pleased. And now we have another question asking if anything can be prescribed off label.
Yeah, so yes, the comment about bupropion and naltrexone, that goes for methamphetamine use disorder, that goes back to that trial that was published. Again, I think it really probably works for some people, and that's probably why we saw that statistically significant effect. I think it just doesn't work for everybody. So I'm really happy to hear that it's actually being used in clinical practice. So I will note, I am not a clinician. I am not a physician. I am not a nurse practitioner. I am not a PA. I don't prescribe anything. I cannot advise for whether you as a clinician can prescribe or not. But yes, we do see things being used off-label for people with stimulant use disorder because there is nothing approved. So if you're a clinician, operate within your licensing guidelines in terms of what you can prescribe and what you can't prescribe. But there are some medications that appear to be effective. We've talked about naltrexone and bupropion. Modafinil is one that appears to be prescribed sometimes off-label as a treatment for stimulant use disorder that people have used. All right. So I've alluded to this a little bit, and I think that the last set of comments sort of got to this is, so we haven't advanced the stimulant use disorder pharmacotherapy, and why is that? So one is that we've really focused heavily on opioid treatments, and that's not just the current opioid overdose crisis. And I want to note that we rightly have focused our resources on opioid treatments because they have been sort of a major driver of overdose mortality. So I'm not criticizing that. But if you go back to the 40s and 50s, when methadone was first being developed, there was sort of a group of leading scientists, both in the government and in academia, and they had enough resources to advance either an opioid treatment or stimulant treatment. And the idea was, the decision was made to advance a treatment, methadone, and really at the time it was for heroin use. And so that's sort of why we are where we are, at least having a couple of opioid treatments. I'll note that they're not enough, and I note that not enough people get them, but the focus from early on has really been on advancing opioid treatments. That was the decision that the field sort of made. I would note, I've already talked about, there's a very high bar for treatment efficacy until recently, right? The FDA has said, take this chronic relapsing disorder and make it so that it isn't chronic and relapsing, right? Promote abstinence 100%. People can't have a slip. People can't have a lapse. And that's the only time that we'll accept a medication as effective from you. Now, the FDA, again, has issued guidance not that long ago saying that they're open to non-abstinence outcomes, but we just haven't advanced a medication for a non-abstinence outcome yet. I think that, another one, and I'll note that these are all my opinions. You may disagree with them, but I feel that there's been a reluctance among society to advance a treatment that is considered to be able to be misused or have abuse potential. And I don't love that term, abuse potential, but that is a term the FDA uses. The idea that a medication could be misused if it's prescribed. So what I'm referring to there is D-amphetamine, right? We know that D-amphetamine is a Schedule II medication. So it, according to the FDA, and I don't disagree, can have some abuse potential. But I think that there's sort of, perhaps some inconsistency there, because we know that opioid treatments also, methadone can have abuse potential, right? So something has changed from when methadone was advanced to when we're looking at stimulant use disorder treatments, and we're not going to advance, even if a treatment is effective, something that might be misused. I've heard this for as long as I've been doing this, that the pharmaceutical industry does not actually think it's worth the investment, that they're not going to make their money back in investing in a stimulant use disorder treatment. Again, I don't agree with that statement, because we know it was Reckitt, but it is now Indivior, has made plenty of money on advancing buprenorphine as a treatment for opioid use disorder. So pharma partners can indeed see that it is worth the investment in advancing a stimulant use disorder treatment. Another thing that I'm thinking about a lot more lately is that stimulant use disorder commonly occurs with other problems, right? Like opioid use disorder or alcohol use disorder, and that we know that sort of co-occurring disorders make it harder to treat either disorder. And so I think we've been trying to treat, just stimulant use disorder or just opioid use disorder. And that's why the stimulant use disorder treatments we've tested haven't been as effective as we'd like them to be, because we haven't actually tackled both problems at once. And then I certainly welcome any ideas you have about why, or if you all have questions about what's on this slide or anything else I've said, certainly happy to pause and take those.
Yeah, someone has said they think with stimulants it's more of a mental obsession, as to where opiates can be more physical. And someone has said, unfortunately, depending on what it is, if it's a controlled substance, many pharmacists may not be comfortable filling a prescription that has to be off-label. And someone else said some people have untreated ADHD.
Yeah. So I'll try to remember those. I might, because I'm going to react to each. The first bit sort of being more psychological or mental than physical. I agree, right? Like opioid use disorder has a very sort of specific and frank physical withdrawal syndrome. That's not to say that there isn't sort of a psychological aspect to it. For stimulants, particularly for cocaine, I don't think we see as sort of robust of a physical sort of dependence or withdrawal syndrome as we do for opioids. Second, I agree, right? If you're prescribing off-label, right, there's very specific rules in Kentucky about what and how you can prescribe things off-label. And of course, pharmacists might not be comfortable, clinicians might not be comfortable writing those prescriptions. And so I think you'll see the things that are used off-label are sort of the Schedule 3, Schedule 4 medications that may have fewer restrictions on them. Again, going to back to that idea of a drug having abuse potential. And then last, ADHD, absolutely. There are data to suggest that if you can treat somebody's ADHD if they've got a comorbid stimulant use disorder, that can benefit the stimulant use disorder as well. Great comments. Any other thoughts about this slide before I move on? And I'm looking at time. We're doing great on time. So, all right. So, I just thought I'd also note sort of why we may have fewer stimulant medications. So again, this is not to criticize NIDA. NIDA is the world's leading funder of treatment screening for substance use disorder. And but what I want to point out, and this is on their website, is these are the phases of trials that they have currently funded for opioid use disorder. So early preclinical, this is sort of rat work, molecular work, developing a specific sort of molecule. Late preclinical is sort of monkey and rat work, looking at sort of the target of interest of stimulant use disorder. We've already talked about phase 1, phase 2, and phase 3 trials, and these new formulations would be sort of phase 4. So this is a lot of medications, which is great. That gives me a lot of hope that we've got new medications coming forward for opioid use disorder on the horizon. But when we look at the stimulant use disorder pipeline, it is much narrower. Right, there's a little bit of early preclinical, there's phase 1, phase 1B, phase 2, no phase 3 medications. Again, not to be critical of NIDA, this is just, there's been less investment overall in advancement of testing and advancement of stimulant use disorder treatments.
Bill, I'm sorry, there was a question on the previous slide about one of the medications. Yeah, and I might say this medicine wrong, so I'm sorry if I do, but semaglutide. The question is, isn't that the same as a weight loss medicine?
Yeah, I joke that we're testing GLP-1. So semaglutide is a GLP-1 medication. It's used to promote weight loss. You see advertisements for GLP-1s everywhere. I will note that this featured largely at the most recent College on Problems of Drug Dependence meeting, these GLP-1 medications. So I think before too long, we will see these being tested for every substance use disorder that we know about, because they appear to be effective at promoting abstinence or reductions in use. But yes, you're correct. That is, I believe semaglutide is, uh, it's not Wegovy. But yes, it is. It's a GLP-1 medication. So, and you'll see that there's multiple here. This means that there are 3 phase 2 trials being done with ketamine, 2 phase 2 trials done with semaglutide. So like, there's a lot of investment in these medications to move forward.
Carissa is asking, what about Wegovy?
So Wegovy is also I will say I don't a weakness of mine is I often use the sort of generic name, so that would be the zolmitriptan or semaglutide. But Wegovy, I don't remember the generic name for it, but it is similar. It's a similar drug. It's a GLP-1 drug. Injectable, that we would presume that if semaglutide works, Wegovy, which again I don't remember the generic name, also probably work in a similar fashion. I think semaglutide is Ozempic. Now it's finally come to me. So I had to sing it in my head, that commercial. So to get that. All right. Any other questions, comments about these? All right. So moving forward, here's some thoughts about where I think we need to go. First, we absolutely need to increase the pipeline of stimulant use disorder medications. And I can say from personal experience that that is happening. In the past 3 months, I have received grants from NIDA to study a novel medication for methamphetamine use disorder and a novel medication for cocaine use disorder. So NIDA is making investments in stimulant use disorder treatment. So I'm very thankful for that. So we will see those drugs don't appear here, but they will appear here, I think, before too long. I think we also, as a field, need to demonstrate the benefit of reduced drug use as a target for pharmacotherapies, because then that way the FDA will accept that as an endpoint. Even our most effective treatments, deamphetamine, for example, in cocaine use disorder, promotes reduction in use, not necessarily abstinence. Contingency management, which some of you may be familiar with, is a way to sort of promote specific treatment targets. Doesn't always promote complete abstinence. It's our most effective treatment, hands down, for stimulant use disorder, and often it's promoting reductions rather than abstinence. So I think if we can say to the FDA, really reduction is a good target, they'll start accepting that, and we may get actually treatments advanced with that evidence. I think, again, this goes back to sort of the reluctance to advance a medication that the FDA indicates has abuse potential, both, sort of societally and, right, clinicians probably have concerns about this. Although I'll tell you, when we've tested deamphetamine in people with cocaine use disorder, they really don't, they don't think a whole lot about it, right? It does not have sort of that frank behavioral effect that cocaine does, particularly if they're smoking it or injecting it. We need to demonstrate to industry that the investment is worth making, both because it improves people's lives, which I would like to think is a significant enough, a substantial enough reason to invest in a medication. But again, pharma companies have a board of directors and have investors that they're beholden to. So financially, that this is a worthwhile investment. And I think we need to think about combining potential treatments with treatments for co-occurring problems, so like opioid use disorder, to be more effective. And so, for example, diapropion naltrexone treatment for somebody with methamphetamine use disorder is great, but we could not give that to somebody with opioid use disorder if they were currently physically dependent on opioids, because they would go into withdrawal, right? That would not be a great experience for them. And I certainly welcome any thoughts you all have about other things we can do to advance medications.
And while we give people time to answer that, we also have 3 questions for you. What about ibogaine? Or do you want me to ask them one at a time?
Well, hold on. Let me write notes down.
Okay. So we have, what about ibogaine? Another question is, do you have thoughts about non-drug use related outcomes that would be important for a clinical trial? Like, do people study quality of life, family, relationships, things like that? And then, and I apologize, but I'm not used to saying a lot of these medications, so I might start saying some of them wrong, but amphetamine and dextroamphetamine combination, is that used to treat attention deficit hyperactivity disorder? Has it been tried in stimulant use disorder?
Yeah, sure. Okay. So ibogaine. I will say I am on record for having concerns about ibogaine. So hopefully what I say isn't going to make anybody upset. Um, I I'll start by saying I think that we need to be doing more research studying hallucinogens and psychedelics for stimulant use disorder. So that's point one. I have concerns about ibogaine. Ibogaine in and of itself has a dose-related effect where it um, can cause heart arrhythmias and lead to death. So I have concerns about ibogaine in and of itself. Now, there are novel isomers of ibogaine that are out there that don't have that heart issue that I think are probably worth studying, right? So ibogaine in and of itself, I've got concerns, but I'm open to the idea of sort of safer ibogaine analogs. But I think the jury's out. I think we need to do more research. I think, a lot of people are reporting that drugs like this really help them, but the sort of controlled research that the FDA requires to advance a medication has not been done. Okay, so non-drug use outcomes. Absolutely, I've got thoughts on those. So I think quality of life is a great general indicator, right? And pick your quality of life indicator, right? Like, is somebody sleeping better? Is their mental health better? Is their mood better? They have better interactions with their family. All of those things I think could be on the table as a non-drug use indicator of a treatment being effective. We just have to prove that it is, right, that it is an effect, that it is a reasonable target to the FDA. And then the amphetamine deamphetamine combo, so like an Adderall type approach, yes, is used to treat ADHD, has been used, tested in for cocaine use disorder. I don't know that it's been tested for methamphetamine use disorder. And just like deamphetamine on its own, does show efficacy for treating cocaine use disorder. I think I got all three questions.
You did, yes.
Okay. Other thoughts? Thoughts about moving forward? Thoughts about things that I have missed? Things that you disagree with? Other things? I'm happy to, again, this is really open time.
Okay, we have a question. Can people with stimulant use disorder have their ADHD treated, or is there danger of abuse?
So I think they absolutely can have their ADHD treated. I think that's a discussion to have with your clinician, right? Whether you're seeing a nurse practitioner or a psychologist or psychiatrist, they may have specific thoughts about what they treat you with, right? They may want to try something like Strattera, or even though it would be off-label, modafinil, before they would move to something like Ritalin, or which is methylphenidate, or an amphetamine containing product. But the thing is, those sort of methylphenidate and amphetamine containing products all are time release these days. They can't be tampered with, so they really I think if a clinician proceeds with caution and that's what's effective for somebody to treat their ADHD, there's a way to do that safely and responsibly for someone who has or has had a comorbid stimulant use disorder with their ADHD, or that's tied to their ADHD, right? Like, might be considered sort of like a self-medication approach.
Do you think stigma plays a role in why there's more medications for opioid use disorder than stimulant use disorder?
Oh, I absolutely think that that's the case, right? We've seen data to suggest that, and what I'm about to say, I want to say I don't agree with this being the sentiment, but data suggests that, for example, people with methamphetamine use disorder experience stigma from people with other substance use disorders, right? That, like, somehow people who use methamphetamine are looked down upon by pretty much everybody else. I don't agree that that's what happened. I can see that is what happened, but that is, I don't want that to be happening. I don't like that to be happening. But I think because stimulant use disorder, and particularly methamphetamine use disorder, is so heavily stigmatized that interferes with our ability to bring treatments forward.
So can you talk more about ketamine in general and as a treatment for cocaine or opioid use disorder? Are you worried about abuse of ketamine as a concern?
Yeah, so I mean, I think we've seen real dangers posed by sort of un unmonitored ketamine use, right? Like, I mean, we know Matthew Perry died from using ketamine, but I think the clinical model for ketamine is really interesting, right? So it's approved for depression. So I'm going to talk sort of about that, right? Like where it's sort of you get sort of a discrete set of treatments with ketamine monthly or whatever your clinician prescribes, but you aren't taking ketamine every single day, and that promotes remission. I think that type of model where somebody with an opioid use disorder or cocaine use disorder, amphetamine use disorder goes into a clinic and gets a ketamine infusion and is monitored, and it's happening once a month, right? That is actually probably a reasonable way to use ketamine and responsible way to use ketamine. And actually it appears effective. Like I've seen data out of New York City where there's a leader up there. His name is Elias Dakwar. He's used ketamine to treat people with cocaine use disorder, and it looks to be pretty effective. Using again that model where somebody comes in, receives an infusion of ketamine, is monitored for however long that duration is, but then goes out and then comes back a month later for their next treatment, right? So that they're not out just sort of using ketamine in their daily lives as a day-to-day treatment, right? It's sort of discrete single treatments administered by a clinician in a clinical setting.
So I have a question that says, hopefully this is okay to ask, but are you worried that what if the FDA is not open in coming years given the political realities, and what about general threats to science?
Oh, goodness. Okay. So so I do think the F well um I think the FDA is open to treatments currently. I think that, we are seeing NIDA fund stimulant treatments. Now, I know that NIDA is not the FDA. They are separate institutions. But I think that, we've got a Secretary of Department of Health and Human Services who has a history of substance use disorder, right? He understands this. I think that it's a real priority for him and for all of HHS to advance treatments for substance use disorder, stimulant use disorder included. So I am hopeful that will remain. I think that there's real interest in psychedelics again for substance use disorders at sort of that leadership level. So I think that we might see things advance. In terms of threats to science, I mean, I know as much as everybody else, right? I'm concerned. I'm concerned about budget cuts. I'm concerned about um, um, sort of how academics move forward doing this research. But I go back to I have seen, for better or worse, both the director of NIH and the director of Health and Human Services speak specifically about advancing substance use disorder treatments, and that gives me some hope.
So what about trauma as it relates to stimulant use disorder? And do you think doing a more effective job of treating trauma would help?
Oh, absolutely. So, I mean, I think we all know that trauma underlies pretty much every substance use disorder. Stimulant use disorder is not an exception, right? And so I think that that addressing issues of trauma are critical to treating stimulant use disorder. I think we as a field have not done a great job of that, right? Like often people with PTSD, as an example, are excluded from trials for substance use disorder, from medication trials for substance use disorder. And so I think, while this whole talk today is about medications for stimulant use disorder, what I haven't said yet, and I really am remiss for not saying it, is I don't think that any medication on its own is really the model we need to be using as a field. I think we need to be thinking about individuals holistically and addressing, right? So yes, a medication probably is warranted, but addressing trauma, addressing stress, addressing anxiety, that all sort of contribute, and that isn't all solved by medication. That's solved by doing the work with that individual behaviorally, cognitively, to address those sort of underlying issues that are probably driving a lot of the problem.
Can you speak to what is EMDR and whether that works for stimulant use disorder?
So EMDR is the sort of the eye sort of training and tracking treatment. Is that correct? I want to make sure that I'm talking about the right thing.
Carissa, if you wanna respond to that.
It's eye movement desensitization and
Okay.
reprocessing.
Okay, so yeah, so that is what I thought what I thought it was. I will say I don't know a whole lot about it, but I do know some individuals who've had experience with it. I don't know that there's data about it for substance use disorder or stimulant use disorder, but I do think it appears to be effective for things like trauma and stress and anxiety. And so if we're sort of talking about underlying issues, if that's effective there, then maybe there's some sort of distal effect on substance use disorder.
What would your take-home message be for someone who has a participant that has a stimulant use disorder and they're still struggling? Is it that they are just not able to receive medications for stimulant use disorder at this time?
Oh, no. Well, I will say that it is unacceptable that we don't have an FDA-approved medication for stimulant use disorder. But that doesn't mean that there's not hope that there will be one. I think the other thing is that there are clinicians out there who get it. And I think that you can work with your sort of clinical community to identify somebody who is willing to think thoughtfully, responsibly, but creatively about potential medications that might help this individual meet their treatment goals, right? We're probably not going to be able to be prescribed deamphetamine, right? Because of various things that we've already talked about today. But there are medications that might help in other ways. And I think that there's a way that if you can help connect that person to clinicians who can get them those medications they need and get them the behavioral support and treatment that they need, that's the way forward currently. We are working on it. We are trying to advance these medications. But, in the interim, if this person really wants help, don't do nothing. Try to connect them as best as possible.
That's all the questions we currently have.
Okay. So we're at about 47. How are we doing? Any other thoughts, comments? I don't want to necessarily end early, but I'm also not going to, make everybody just sit in silence unless you want to.
I don't see any more questions coming through. Could you maybe share your slide with your contact information one more
Oh,
time?
sure, absolutely. Yeah, let me get to that. And I will, and Brooke, I will email you the slide deck, and you're welcome to share
Perfect,
these with
thank you.
everybody. So this is the slide deck again. My email is just william.stoops@uky.edu. I'm also on X or Twitter. I still call it Twitter, and Blue Sky.
I don't see any more questions, just lots of thank yous in the chat.
Oh, it's been my pleasure. Certainly reach out if there's anything else you want to know about. I wish I had more concrete answers for you all. But we're trying. So
Well, we so appreciate your expertise in being on the webinar today. I mean, and your devotion to developing medications for stimulant use disorder. Yeah, and sharing with all of us and sharing us about the process.
of course.
So
Well, we
now,
actually do have a late breaking question that just came through that says,
Okay,
cool.
all right.
do any of your research studies focus on the link between this and housing and food insecurity?
Oh wow, yeah. So I will say most of what I am doing are sort of those phase 1 sort of safety tolerability type trials, right? So for most of our studies, we're actually housing individuals in a hospital where we're doing our studies. But the most effective treatments that have been tried for substance use disorder, for stimulant disorders, also include sort of that um, uh, uh, the addressing barriers to care, things like being unhoused, things like food insecurity, right? Helping individuals get access to those resources, because that is also such a major part of the problem, right? People can't access the things that they need, let alone get the treatment that they need for substance use disorder. So linkage to care is really, really critical. But most of my work is before really that level. In fact, a lot of the work that I'm doing is not in folks who are seeking treatment. It's again that sort of phase 1 safety stuff.
Yeah, I think that's it for the questions. Thank you so much again, Dr.
My
Stoops.
pleasure. Thanks you all. It's just been really, really terrific. And certainly feel free to reach out if there's any, if you ever want to ask about anything, or if I can help or offer advice or thoughts. So
Wonderful. So now we're going to transition into a resource spotlight presented by Tara Stanfield and Dr. Hartley Feld. Dr. Feld is an associate professor at the University of Kentucky and partners with Voices in various capacities. And she's also a board member at HealthFirst of the Bluegrass, which is the resource we'll be spotlighting today. And joining her is Tara Stanfield. And Tara is the Chief Integrated Care Officer who first joined HealthFirst Bluegrass in 2017 and immediately went to work designing and implementing their integrated care model. Tara has worked to embed behavioral health consultants into the primary care teams, create community health worker positions, build access to psychiatric and traditional therapy services, introduce medication treatment for patients with substance use disorders, and maximize healthcare telehealth capacities. So Tara loves working for an organization that advances her passion for equity and inclusion. And when away from the job, she supports the Wildcats, woohoo, travels and spends time with her amazing family. So I will turn it over to Tara and Hartley.
All right, Hartley, you want to go ahead and share my screen?
Yes, please. So I am going to be kind of a moderator, pop in and ask questions and let her know if something's in the chat or some of the things that I might be more aware about their services related to reproductive health that I could speak to. But thank you so much. Tara's the expert here.
Am I sharing?
No, you were sharing not in presenter mode, and then it went away.
Sorry, Hartley.
So close. No, it's okay.
It's not sharing?
No.
Okay, hold on just a second.
There you go. If you just click on your presenter mode.
Sharing now?
Yes.
Great.
If you could click on your presenter mode, though. There you go.
Awesome. All right. Well, thank you all for having me this morning. I'll tell you a little bit about myself. I came to HealthFirst in 2017, coming out of working in specialty addiction for the previous 12 years. I was working in a setting that was really an awesome place to provide substance use services because we had all but detox level care continuum. We operated a opioid treatment program, so we were able to provide methadone services. We had a residential clinic. We had IOPs, outpatient therapy in multiple counties. And so it was really great, and it was fun to be in there operating those programs and making sure we had the best clinical model. And it was really during a time in Kentucky when, everybody's talked about opioid epidemic for the last 10 years, but we all know it's been around for much longer than that. But that was a time that it was really a hot topic. And so it was exciting to work in those programs and try to advance those levels of care as much as we could. But what I kept finding over and over, especially in the residential program, because we would do, as you guys know, we would had some mandatory regulatory rules that said we had to do blood work on our patient and on our patients that were coming in. And oftentimes we would have anywhere from 60 to 80% of our patients who were checking in during that time, who were testing positive either for the first time or maybe they already knew for infectious disease. And it was folks that were really medically sick, even if their symptoms hadn't started to show, and all they had focused on so far, was their substance use disorder and trying to get stability there. But our program, because it was a substance use treatment program, didn't really have medical access. And so a lot of times patients would be coming from different counties across the state where they had burned a lot of bridges with the medical practices, and they didn't really even have anywhere to go to follow up with their care, or they lived in a place where they wouldn't have access, easy access to good, solid medical care. And I always just felt like, we're providing this great substance use service, but people have a ton of other needs. And on top of medical care needs, the amount of patients that we saw in treatment, especially in that residential model, when you're really looking at folks every day, and see the changes that they make after, a week and a half of not using, but then comes oral pain or, dental related problems that have been neglected for a long time. And I just always felt bad, and wouldn't it be awesome to be able to really help and have a little more power to help those patients. So sometime around 2017, HealthFirst Bluegrass reached out to me, described what they were at that time and described what they wanted to become with this integrated model where patients really had a high efficiency program that offered dental services, medical services, behavioral health services, treatment for substance use in settings where all those providers were working together. And I was like, I'm sold. This is it. I'm ready to do it. And so we've been working hard at it since that time. And I'll run through these slides with you guys, and I can't see you. So Hartley will help me if any questions come up. So HealthFirst has been around in some form or fashion for over 30 years. Up until 2015, we were located at the health department. So a lot of times people think HealthFirst currently is still the health department. We are not. In 2015, we saw a need to kind of break off from our health department services and build a federally qualified health center, which is what we are now. We're serving over 20,000 patients a year. I think this year we're upward of 25,000 patients. We have 16 locations, all in Lexington. We will accept patients from outside of Lexington. We have patients that come from other states for services sometimes. We don't care where you live, but our locations, we're really focused on making sure we're meeting the need in Fayette County. Services offered, we offer primary care for adult and pediatrics. We have OBGYN services and women's health. Our women's health team, I think on average, delivers about 300 babies a year, but last I talked to them, this is a banger year for some reason, and they were thinking they might get to 500. We have OBGYN providers who deliver babies at St. Joe down the street, but they do all of their prenatal work here and their follow-up here with us. We have dental. We have 2 dental clinics, one large dental clinic here on Southland Drive where I'm at, another on Midland and 3rd downtown. And then we have some pretty fancy mobile abilities and love looking for opportunities to partner for mobile dental services. We have a behavioral health team that's sprinkled across those 16 sites. We have on-site pharmacies. We have 2 pharmacies and offer free delivery. And we have school-based clinics in 10 of our Fayette County public school sites. I'll talk to you more about the school-based clinics in a second. What guides our providers? This is, for me, the most important slide on the deck for the day is that our providers and the people that we hire to work with our patients, we really make a point to make sure that we are getting team members who understand that we are here to treat anybody that walks through our door with dignity and respect, and that we are an environment that will be free of judgment. As far as substance use goes, we recognize substance use disorder as a chronic illness. It is not a moral failing. There's nothing to get me worked up more than when I'm in a setting and hear any conversation around substance use disorder as anything other than a chronic illness. and should be treated as so. We understand that every recovery journey is different. I appreciated Dr. Stoops' comments on that earlier. We serve everyone. We put a big focus on making sure that groups of folks who might be experiencing health disparities or at higher risk for poor outcomes, that we're outreaching to those groups. So we put a big focus on our LGBTQIA plus community. We have 2 clinics that are located in shelters where people are experiencing homelessness. One at the Hope Center and one at Catholic Action Center. We are very wide open door for immigrants and refugees, and we really serve people of all socioeconomic backgrounds. So we have patients that have the best insurance and the best jobs, and we have patients that really need some help and maybe are uninsured or not eligible to get insurance and just need some help for medical and dental services. We cover the full continuum of people. Things that make us different. Like I said earlier, we really focus on compassionate and collaborative, whole person focused care. We don't want to just see a patient and a primary care model and take care of their diabetes. We want to make sure that their diabetes needs are met and that they can afford the medication, and that if there's anything else going on in their life that they need help with that would prevent a positive outcome, that we're addressing those things too. We really focus on team-based care to make sure that all those providers are talking together. We share electronic health records, so behavioral health providers can see what's going on medically and vice versa. That's very powerful for making treatment plans for our patients. We accept most insurance, and also, maybe the coolest thing that we do is we're here for people regardless of their ability to pay. Because we're an FQHC, we're allowed to be set up in a way that allows us to provide sliding scale options for patients who don't have access to insurance. We see a lot of patients who really are not going to be able to get insurance. We also have patients that come through the door, people that come through the door that are eligible and don't know it. So we have team members here who are connectors. I think we have 12 connectors in our clinics now that are working to help make sure we're linking folks to coverage if it is at all available to them. But if it's not, we still want to see those people. We still want to take care of those patients.
Tara, can I jump in and interrupt you real quick? Sorry, this is Hartley. FQHCs are federally qualified health centers, and some of the folks on here are from Louisville and some other parts of the state. So you can find FQHCs in several communities in Kentucky. The largest one in Louisville is the Family, what's it called, Tara?
Family Health Center.
Family Health Centers, yeah, and they have several locations. So we aren't covering those today, but there's a lot of standardized practices with federally qualified health centers that have similar mission, similar goals. And so you should be able to find a lot of these resources in other communities. I think some of them are pretty limited for dental, so it might be unique to Lexington. Thanks, Amanda, for putting that in the chat. I just wanted to pop that in there because I think I was supposed to provide a slide for that and I forgot. Thank you.
Thanks, Hartley. Yeah, every time I get on a call with the family health folks in Louisville, I leave impressed. They're a big center. They do a lot of super cool work. Their behavioral health service line in particular is quite impressive.
We have a question, if that's okay. I'm sorry, before you get back to your slides. Is there a way for female individuals to get sterilization services at your clinic?
Like birth control or implants?
Like their tubes tied.
I'm not sure. I could follow up. I'm not a very good women's health representative today, but I could follow up and get that back out. Hartley, do you know?
Yeah, so I think what would happen is they would be seen by one of the OB-GYNs there, and they would schedule them for one of their partners that is a bit more hospital based. And so I think you can get access to getting your tubes tied, but it might not be done in their clinic rooms because that's a bit of a procedure. But yes, it's a good starting point to find somebody to kind of get that set up for you. And they do offer birth control, other birth control in the women's health clinic and with the OBGYNs. Last I had checked, a lot of the sites that are with our unhoused populations with the Hope Center and Catholic Action Center, they had the Depo-Provera shot and birth control pills, but they were kind of limited. And if you wanted more access to different options, it's better to go to the Southland Clinic or the Met. And those are both absolutely beautiful clinics. I just wanted to kind of jump in there because if you haven't been there in a while, they're amazing. They're new and fabulous. And you could just kind of pop in and see what they have to offer as well. There's sort of an open door and information desk at the entrance.
Well, Hartley, I guess
there's
it's
my
great
plug.
that you all are sort of tag teaming this because I know this is your specialty. Because now we have another question asking if you can get reproductive health services at St. Joe, because perhaps in the past not.
St. Joe, I'm sorry, Tara, I'll jump in here too. So St. Joe, because they're a Catholic organization, has limited services for reproductive health, but there is like a clinic that they send you to that is nearby St. Joe, but technically not in their hospital, so they're allowed to do it. But the nice thing about HealthFirst is they're not tied to just one hospital. So they have an arrangement to deliver at St. Joe's. They also deliver high risk pregnancies at UK, or they transfer people to both the Pathways program and some of the high risk OB to UK. So they're open to other facilities. So I do think that there's a way to transfer folks to get the care that they need. Are we good?
Any other questions?
Don't see any more right now.
All right. You can see our health equity statistics there. 67% of our patients have a racial minority and 33% non-English speakers. We do a lot of work to make sure that our sites are inclusive and that we are managing languages both in our documents and in our abilities to interpret during patient visits. All right, behavioral health, integrated behavioral health. This is my world. So we offer therapy. We have therapists. I think we have 16 therapists currently. We offer medication management. We have telehealth. We went to full telehealth during COVID. Our behavioral health team did, to give our medical teammates our space really so they could spread out. And outside of COVID, we're currently seeing around 38% of our patients have chosen to continue telehealth. They really like to have that behavioral health service delivered. And when I say behavioral health, I mean behavioral health and substance use. Those are in the same family for me. But still at around 38% telehealth. We embed behavioral health clinicians into our primary care team. So if you're receiving services at a site that has at least 4 medical providers, we put a licensed clinical social worker on that team so that they can respond to on-demand things that might come up when patients are being screened for depression, anxiety, substance use, and provide brief intervention right there on site in the primary care visit, or assessment and referral to our more traditional services that we have here, or potentially even a referral out for a higher level of care. And we're currently we have a small MOUD patient population. We have limited that service to our primary care patients over time. So we've kind of kept it small so that we could keep it not necessarily like a MOUD clinic, but just part of your primary care experience that you have, where you come in, you see your doctor for any other health conditions you have, and they treat this alongside just the same as they would anything else. We're currently seeing a 6-month retention rate at 52%, which is significantly above the national average. So always open to that service. One of my favorite parts of HealthFirst is our community health worker program. So our community health workers are kind of like primary care's version of case managers. Of our behavioral health substance use patient population, 15% of them work with a community health worker. We'd like to see that increase. We think community health workers are helpful for everybody. I would take one personally. They do things that look at social determinants of health. So they do a lot of appointment navigation, helping make sure people are getting where they need to go. They spend a ton of time working through transportation issues. They are Uber and Lyft experts to make sure our patients are getting to their appointments, both with us or to specialists. They are all connectors, working on benefit assistance, and then housing, food, legal resources, you name it, anything that comes up in a patient's life that is impacting their health. They spend time working with code enforcement. They work with landlords. If you have a kid that has terrible asthma and is living in a house that is completely eaten up with mold, there's not much the medical provider can do, but the CHW can get in there and put some pressure on that landlord and be a huge support to those patients. They also operate our patient assistance fund. This is a fund that we have that people in the community make donations to, our staff make donations to, our big vendors that work with us donate to it. And it's really for kind of crisis needs that come up for our patients, that there's not something, there's not an app for that. There's not a community resource that we can find for it. It's a fast thing that needs a fast turnaround. That could be anything from some utility assistance that we're able to offer, food insecurities. I mean, winter time and there's nowhere to get clothes and a family's been displaced. We're going to go make sure everybody's got jackets or bedding or whatever it is that they need. So really cool program that we have attached to our community health workers.
Terry, you've got some good comments and questions in the chat. So one of them is psyched. I think it's nice to get MUD at your primary care instead of recovery center. I mean, it's just such a nice option that people can be treated at a place where they can get so many more of their healthcare needs dealt with, but also not as it's like you see the whole person in a way that's different than perhaps they might get in another facility. The other question was about, and I have asked this a little bit, so Tara, maybe we could have a little conversation about this, but Amanda said, do you want to clarify how a recovery coach could work with a community health worker to coordinate care for a participant together? And so, and just to be clear, when the community health workers presented to the board, and we've done some site visits where they work with clients, I've always asked that is, can somebody come in? Can Voice of Hope refer somebody there? And just to go to the community health worker. And the idea is that you have to be registered as a patient first. And so you would sign up as a new patient, and then you could ask for or be able to see a community health worker. They were working on a system where you could actually see the community health worker before you see the provider. And I'm not quite sure if that's been figured out yet, if you know, Tara, as long as they're registered as a patient.
In our current model, all of our behavioral health service line, community health workers, behavioral health services are available to patients who are established medical patients. So it happens every day, all day, that somebody comes in and establishes medical, because their real goal is receiving behavioral health services with us. We know that happens. We are currently looking at opening our behavioral health service line to the community. We kept it closed for a long time since the beginning of building the integrative model, because we're a patient-centered medical home, and we wanted to make sure that we're able to respond to the needs of our patients. And we were afraid if we open, psychiatry in particular, to the community, that we wouldn't be able to have that fast access. Our model, I don't know if any of these slides talk about it, but we're really focused on meeting the need when the moment's hot. For behavioral health in particular, if something is going on and you've taken that moment to say, I'm going to reach out and I'm going to ask for help for substance use, the same, and you get a visit that's 6 months down the road, the likelihood you make it to that visit goes way down. We want to be able to respond within a couple of days, and even oftentimes same day. So for that reason, we've kept it closed, but we are currently, for the first time since I've been here, I'm excited, and I think it's going to happen, working on a direct line. If somebody has primary care established elsewhere and they want to keep that as their primary care doctor, that they can come straight through to behavioral health. I don't have a timeline for when we'll be able to open that up, but I'm hoping, within the next couple of months.
But if they wanted to see you all for primary care and then do all of the other things, dental, behavioral, how long is that for a brand new patient to be able to get access?
The medical visits, the last I've seen, I think their goal is under 8 days to be able to get new patients in within 8 days. Sometimes you
Yeah,
can
that's
call and get an appointment on the same day if, if there's cancellations, but yeah, they're really trying about 8 days. And on behavioral health, we are even child psych, can run up to around 2 weeks, but usually within a week or two for adult, we're able to get folks in.
if they're already patients right
If there
now.
are, yes,
Okay.
yes. Yep.
So it sounds like it's a good idea to kind of get established as a medical patient as for primary care purposes. And you can just even do like a wellness visit. It doesn't have to be for a medical complaint. And then establish and kind of move your care there if you wanted to, and then you would have better access to the behavioral resources. Okay, thanks for spelling that out. Let me see if there's another question. Oh, okay, never mind. So there's a Q&A and a chat. So I wasn't looking at both of them, but thanks for being patient with us. Could you tell us if for the dental care, what services that you offer and how long the wait is there?
So a difference about dental is you can come straight through for dental services. They offer routine dental care. They have a surgical site here at the Southland Clinic, so they can do some more advanced work here. They are able to do some like denture work. I think there's some limits on that. I don't, I think the majority of their work is more, routine care, maintenance care. They focus really hard on making sure that they're closing out complete treatment plans for patients. So dealing with the moment when you come in and you're in pain and whether you need a tooth extracted or a cavity filled or whatever, that they're complete and full treatment plans. We have a partnership with UK that we can refer to them for a more advanced level of care, or sometimes pediatric care requires a little bit extra sedation type of services. So they do assessment here and then refer out if needed.
I just want to plug that their wait times for dental have gotten so much better. I mean, I think the last I heard it was like 2 to 3 weeks out. So establishing care as a dental patient has just gotten way easier. So wait, I don't know if we fully answered Amanda's question. So as you know, the peer recovery coaches work with their participants Voices of Hope works in 11 different counties with participants, but a lot of their work is in Fayette. Can they, and they help connect them, they link them to services in a way that's a really soft handoff for folks who need it. And so would it be providing them a phone number? Can they walk in the door with them? Can they schedule? What would be the best way for a peer coach to try to get somebody connected? Just the phone number?
The recovery coaches or peer support specialists having our phone number. We like for the patient to make that call to set things up. But once a patient has come in, if they agree to sign a release of information for a recovery coach to be involved in the process, we really are focused on person-centered care and whatever makes sense for that person. And if the recovery coach is what makes sense for that person, we want to include them. But yeah, for that first call to make the appointment, just getting that number and our information to folks.
Great. And I also love it's a two-way street. So Tara, on HealthFirst website, you all are a reference for them as well. So you're one of the resources that are listed for recovery services, support services. So
yeah, absolutely.
Yeah. Oh, wait. There's another question. So if a patient has been started on MOUD during a hospital stay, is there a way to fast track them into behavioral health so that they can continue without starting into primary care with an eval?
If they are not a currently established primary care patient?
Right. They started in a hospital stay.
No.
And assuming, because you don't really have a hospital partner. Okay.
No. If they were already our patient, we track all of our patients that are hospitalized, then the answer to that would be absolutely yes. If they're not, then they would have to establish in primary care first.
Great. And then they want the phone number for HealthFirst if they wanted to make an appointment. We'll put it in the chat, and I think it's on your last slide too.
Yeah, yes.
Okay. Okay, perfect. Okay. That's it for now.
All right. So for all the people that you work with that have kids, for your kids, the school-based clinics, when I first came here, I heard school-based clinic. I thought like school nurse with Band-Aids. That's not what this is. Our school-based clinics are full throttle primary care clinics, the same service as you would get in any of our big clinics like the one I'm sitting in right now. They have a full-time nurse practitioner. They have a full-time behavioral health therapist. We rotate psych and dental through those sites. We're located in 10 schools. We really focus on schools that are located, that are in places that are at 100% the free and reduced lunch. We want to be in areas where we know there's a lot of barriers and some struggle, and that it might be a challenge for parents to take off work, to go get their kid out of school, to go to the doctor. And so we want to be there for those families. We also, in those clinics that are staffed by a nurse practitioner who is a family practitioner, which is the majority of them at this point, and not just pediatrics, those clinics are open to the public. So if you're in Lexington, you're close to a HealthFirst clinic somewhere, even if it's not one of our main big sites like this on Southland Drive or downtown and Midland 3rd, because the school-based clinics are there for you. And on our website, it lists all the locations and the sites of where those clinics are at.
At what age are students allowed to have a separate medical record that their parents don't have access to?
Well, that's a doozy of a question. Really 18 when you're an adult on the medical side of things. And honestly, behavioral health, there's a lot of conflicting regulatory rules around behavioral health, around women's health and family practice. But I always think that at the end of the day, the most likely answer you're going to get from any clinic is parent is consenting for the service until the person is 18 years old. There's some emergency things that can happen that can make that rule change, but there's still not a ton of protections around could parent get access to that record. I hope that answered the question. That's a big question. Whoever asked that one, that is a doozy of a question that we deal with a lot. So really trying to decrease stigma by embedding recovery into primary care. We know that a lot of folks just won't go for specialty care, and we feel like, most people do show up to the dentist, and most people do, come to see their doctor so often. And if they trust their medical provider, and we can also offer these services alongside, that we'll get some acceptance from people that might not would have had the opportunity elsewhere. We really want to increase access for marginalized communities. That's why we locate our services where we do. That's why we do all the things to make, reduce barriers. We want trust, dignity, and consistency for all of our patients, regardless if you get services from us here in a big, shiny, fancy place like Hartley described, or if you get services in one of our small clinics that we've set in, across town to make sure there's access. You get the same service. You get the same quality providers. You get the same lab, hospital tracking, quality measures, all the things that we do. And we really, want to focus on this concept of we have a relationship with our patients. We know who you are. We're making your services specific to you. If anybody's interested, we do these things once a month. They're called HealthFirst Bluegrass 101, where we invite anybody who wants to come, community members, providers, patients, future board members, whoever's interested to come. They last for an hour. We do just kind of an overview, similar to what I've done right now about what services we have. You get to meet our provider. Sometimes we have providers there. We usually have community health. Our CHWs, our community health workers there, just to learn about the services, hear some stories about the way that we work, and then do a tour of our facility. The next two dates are listed on this slide, and I can share these slides with you all. The only thing that we ask if you're interested in coming is to give us a holler and let us know, so we'll be prepared for you. But I always find that when I'm telling a patient that I want to refer them someplace, if I've been to that place and seen that place, I feel better about it. So if you guys are ever interested in doing that, just hit us up. And to close, Here's some QR codes for you to link up. Oh, our phone number is not on here.
We put it in the chat with there's
Okay.
a new patient button that they could just go right to, because I
Right.
think you don't necessarily want to call, well, you can call main number, but for the most part, I think that's a better way to get established. Let me see if there's a phone number.
Well, thank you so much, Tara and Hartley. And I'm going to put the link for the survey in the chat one more time for peer support specialist to get a continuing education certificate if they complete the brief survey. And yes, the website link is also in the chat.
We do have another question. Who do you contact to attend the 101 tour?
You can contact me. Let me put my email in here.
Perfect.
I just posted the general number. Oh, Brooke, I think
I'll repost it to everybody.
Okay.
There we go.
Thank you. Okay.
Here's
If
And
you,
Tara, it's
can I
those
say real
community
quick,
days with the, oh, go ahead.
if somebody sends an email to me to do the HealthFirst 101, we have apparently an airtight firewall situation that stuff gets getting stuck in. If I don't respond pretty quickly, call that number and have them shoot me a message so that I can get in my quarantine and make sure I catch you.
We have a question about whether you take DOC reentry patients.
We don't have a current contract with any of the DOC work, but we would absolutely take them on for, just establishing primary care to come in.
And Tara, I have a question about those 101s. Is it, I've been to one at Southland and one at the Met. Are they scheduled at different places, or you can choose which one you go to?
Both of those are going to be at Southland.
Okay. So that's your
And
biggest.
we have on
Right.
for the rest of the year. I just put the next 2 months to keep it short. So if you're ever interested
Okay.
beyond then, just shoot me an email.
So Southland's their really big site, but the Met is also brand new and right downtown and really close to Voices. It's in that little awkward shaped triangle downtown that's kind of been redone.
I think the next one we're doing at the Met is in September, but I believe it's going to be in Spanish.
That's great. I don't see, oh wait, let me see if there's any other questions. Curious about the types of services offered on the mobile unit. And could you talk about the titer thing too? Typhus, I always get it wrong. I make it sound like a disease.
The mobile dental, so kind of the way to think about it, the way we use it right now is they'll go to the schools, take the kids into, when the mobile's not with them, they'll go into the class or into the clinic. Kid comes into a normal medical exam room, they look around in their mouth. And then if they identify that there's something that needs like ongoing follow-up, like they have cavities or need tooth pulled or those kind of things, then the mobile dental can come around and do that. So they, schedule that up and circle it back and do a bunch of kids all
And
on
did
the
they
same
see
day.
adults too?
Right now, the mobile
COVID.
dental right now, I do not believe is going to any adult locations, but that's something we're always open to talking about. I have had dreams since I've been here of what we could do with the mobile dental van in the substance use community.
And then you do have a little unit that can be used by a medical assistant at several community sites where they can actually like look in your ears and listen to your heart and do all of that. And then it goes back to a provider. And there, I know you had one, was it with New
Natalie's sisters.
Oh, Natalie's sisters. So that's one of Voices of Hope's partners, is Natalie's
I don't
sister.
think they're going out to Natalie's sisters anymore, but they were doing that right outside of COVID, I think, for a while. But yeah, we have some TIDO capacities. It's usually with that most about, are there enough patients who would need to have visits to be able to send over like a medical assistant who runs the little machine and looks in your ears. And
Mhm.
I have been a test patient often for that. And so looking inside your own ear while the TIDO is happening is really adventurous.
I thought you were doing that at like Harrison Elementary, the old Harrison Elementary School.
Yeah, they're doing it between the schools. Sometimes if we have a provider shortage, they'll send it over
Okay.
and complete those visits during TIDO. But I don't know of any adult outside providers right now that have but we're always open to all those possibilities. It's mostly about just the patient volume. But yeah, definitely want to always be talking about those potentials.
Great. Any other questions? We made it to our 11:30.
We did make it to our 11th. I don't
Alright.
see any other questions. Thank you again so much, Tara and Hartley, for sharing about HealthFirst Bluegrass. And this whole integrative healthcare model for whole person care is just so impressive, and I'm so impressed by how quickly people can be seen by a provider. But that concludes today's episode of the Kentucky Harm Reduction and Recovery Community of Practice webinar series. We'll see you next month on the first Tuesday in August at 10 a.m.
Thank you.
Thank you all. And thanks, Tara, for coming and for HealthFirst in general. All your hard
Yes,
work.
thank you so much.
Thanks.